Today, let's talk about some 12 lead EKG concepts. Our 12 lead is 10 seconds long left to right. That kind of differs a little bit from maybe you're used to a 6-second strip. We now have a 10-second strip, but our boxes remain consistent. So each box, little box, left to right is 0.04 seconds. Each big box, left to right, is 0.2 seconds. Each little box up and down is amplitude, and that's 1 millimeter. So each big box up and down is 5 millimeters. So left to right is time, up and down is amplitude. When looking at your 12 lead, you might say, well, what are these weird, like, boxy things, like, right? And that's what it looks like to me. What are these weird, like, boxy things? Either the beginning or the end of each tracing, and these are our calibration boxes. So each calibration box tells us that that EKG machine is calibrated properly. A standard box is 10 millimeters high, so either 10 small boxes high or 2 large boxes high, and 0.20 seconds wide. So 5 little boxes wide or 1 large box wide. This tells us that this is printing out at a speed of 25 millimeters per second, and that's our standard speed. So this is our standard calibration, 10 millimeters high, 0.2 seconds wide is our calibration box, and that gives us a standard print speed of 25 millimeters per second. Pay attention to this box. Please pay attention to this box because it um, might be different. The EKG tech might, or the cardiologist, or the nurse, or whoever, might go into the system and adjust it a little bit. One of these calibration adjustments is this kind of like half step. If you see this half step, it's typically complexes are so tall that we have to kind of like shrink them down a little bit. So this half step tells you that these complexes have been shrunk down by half. So when we are interpreting them, when we are applying our typical criteria to interpret whatever for amplitude of complexes, we have to take into account that these complexes are half the amplitude that they actually are. So this kind of half step tells you that these complexes are half the size that they actually are. That was when complexes are too tall, too much amplitude. We got to like shrink them down a little bit. Another calibration box issue or difference that you'll see is this kind of like double wide calibration box. And instead of 25 millimeters per second print speed, we'll print it out at 50 millimeters per second. And if we print it out faster, that means that the rate, or the complexes, I should say, complexes are spaced out further apart. So that means that this patient's heart rate is really fast and we want to space it out. So heart rate is really fast, we print it out really fast, and we see the complexes spaced out a little bit further. So the calibration box itself, instead of being 0.20 seconds wide, is 0.4 seconds wide. It's a little bit wider, it's double as wide as it usually is. The print speed is twice as fast as it is, and we are spacing out these QRS complexes. We're spacing out everything because our patient's heart rate is going so fast that we just want to like just space it out a little bit and see each complex for itself. And now we're looking at our kind of standard 12 lead EKG. We've got our calibration box here at the end. It depends on what machine you're using. Might be at the end, might be at the beginning, but here it's at the end. We'll say this is a normal calibration box. We don't have any small boxes or big boxes to kind of say, yes, this is normal, no, it's not, but we'll say this is normal. Our lead representations. Lead 1, we're going to start at the top left. So lead 1, 2, and 3 are going to be on the left and all the way down. Lead 1, 2, and 3. Our augmented leads are going to be right next to them. AVR, AVL, AVF, all the way down. 1, 2, AVR, AVL, AVF. And then we're going to get into our precordial leads. We're going to start with V1. So V1, V2, V3, all the way down. V4, V5, V6, all the way down. And that's the way every 12 lead is gonna show you. So lead 1 in the upper left hand, V6 in the lower right hand, with a progression of 1, 2, 3, AVR, AVL, AVF, V1, 2, 3, V4, V4, V5, V6. Some machines have a running strip down below, and you can pick which lead you want. Some are lead 1, lead 2, lead 3, V1, V2, V3, whichever you pick down at the bottom. Those are some machines, some maybe not. But this is going to be your standard lead representation on your 12 lead printout. With that, your 12 lead machine reads more than one lead at a time and measures more than one lead at a time. So all those leads in a vertical line here, this like vertical red line, this is all happening at one time. So you see one complex, let's say in lead 1. So here we have lead 1, lead 2, lead 3 here on the left side of the 12 lead. Lead 1, 2, and 3. This red line, this is all happening at the same time, and you're getting multiple views of that same thing. So here we're moving left to right, and again this is a 10-second strip left to right, but vertically we are seeing the same thing in the same time. So lead 1, 2, and 3. If you see a QRS complex in lead 1, 2, and 3 that's happening at the same time, and then we move along time, along that x-axis, and AVR, AVL, AVF, we see the same thing up and down. So if you think you see a P wave in lead 1, follow it down into lead 2, into lead 3. Maybe you see a P wave there as well. If you think you see something like funky with the T wave in lead 1, follow it down. Lead 2, lead 3. Same thing with like V4. You're like, you know what? I definitely see something like funky with the P wave in V4. Follow it down into V5, V6. Do you see funky things in V4, V5, V6, right? So left to right, 10 seconds in time, but vertically, up and down, is happening at the same exact time. All right, moving forward in this course, we're going to be talking about waves and the nomenclature of these waves. So we're going to kind of name them dependent on size, dependent on location, and dependent on direction of deflection. So are they positive? Are they negative? Are they big? Are they small? Are they isoelectric? Where are they in the sequence of things? So that's how we're going to name our waves. Really tall or really deep waves are given capital letters. So capital Q, capital R, capital S. We've got a capital R prime. That's a little like quote, like a little right there. R is R prime. That's an extra R wave. And then our small waves, and this is all kind of a little subjective. This is your like art appreciation course for EMC. You're welcome, right? Our small waves are given lowercase letters, so lowercase q, lowercase r, lowercase s. lowercase r prime. So got the, but it's still a lowercase because it's a smaller wave, and that's why we're whispering. What makes a Q an R or an S, whether it's uppercase or lowercase, or an R or an R prime, or an S prime, or a Q wave is the first negative deflection after a P wave. Always. That is the definition of a Q wave. It's the first negative deflection after our P wave. Our R wave is the first positive deflection, first upward deflection after a P wave. Our S wave is the first negative deflection after the R wave. So our Q wave, negative deflection after the P wave. S wave, negative deflection after the R wave. Q and S, both negative. Just depends on which wave they follow. And then if there is another component, we start with the primes. So another upward component after the S wave is an R prime. If there's another negative deflection after the S wave, it's an S prime, and so on and so forth. Here are a few examples. We have an R prime. So going in, we don't have a Q wave here, right? We don't have a negative deflection after the P wave. Let's pretend there's a P wave here. We don't have a negative deflection. It goes an R, and then R prime. Right? Little r, big R, R prime. So little r, big R. Here we go, big R, little r. But like nothing goes below baseline. Here's our baseline. Nothing goes below baseline, so we don't have any negative deflections. So we have RR prime complexes. We're just naming them big, big, big little, depending on, how they deflect. It's okay. Here we do have a couple, some S's that go below baseline, so we have some negatively deflected complexes. We have RSR prime, big R, big S, big R prime, because that's the second R. Here we have R, S, R prime, S prime. I don't know, that guy's having a bad day. I can't tell you who that guy is. He's having a real bad day. But just to give you an idea of how we name our waves and how we kind of the nomenclature of our waves. That gives you an idea of the bigs, the littles, the primes, and the not primes. Except for that guy. That guy's dead. Moving backwards a little bit, we've got the P wave, and this is depolarization of both atria. The P wave itself, we're not talking about the PR interval, we're just talking about the P wave itself, start to finish, just the P wave, 0.08 to 0.11 seconds. We have a TP wave. You can use that as you want. But we do have a TP wave. It is the repolarization of the atria. This is typically, most commonly, almost always overshadowed by the QRS complex itself, so we don't see it. But we do have a TP wave, that is a repolarization of the atria, just like we have a T wave, which is a repolarization of the QRS, and a repolarization of the ventricles. We have a repolarization of the atria that is overshadowed by the depolarization of the ventricles. So it's in there, and in some conditions we might be able to see it, but almost always it's overshadowed. But just know it's there. Then we have the PR segment, again, not the P wave. So we have a P wave, we have a PR interval, we have a PR segment. So the PR interval is a P wave plus the PR segment. Here we're just talking about the PR segment. It's just this little like right there, right? The PR segment itself. So at the end of the P wave to the beginning of the QRS complex should be at baseline. Anything, 1 little box above or below, 1 millimeter above or below, your book says 0.8 millimeters, but good luck measuring 0.8 millimeters on your 12 lead. So anything, we're just going to say 1 box. 1 little box. Anything 1 little box above or below is like, you know what? Something's wrong. That's pathological. When we say pathological, that's something wrong. So anything greater in your PR segment above or below baseline is something wrong. Let's put all of that together. We got our P wave. We got our PR segment. Let's put it into a PR interval. So the beginning of the P wave to the beginning of the QRS complex is your PR interval. Should be 0.12 to 0.20 seconds long. Anything longer than that, we might be looking at some AV blocks. Might be looking at other things. We'll get into that later on in the semester. But we're looking at the beginning of the P to the beginning of the QRS complex, and that's our PR interval. The PR interval is really important because it contains like everything, right? So it goes from impulse initiation from your SA node through atrial depolarization, through atrial repolarization in your TP wave, which is kind of like hidden a little bit, but repolarization goes through AV node stimulation, through the monophase, through the monobranch, through your Purkinje system into your ventricles. And when it hits your ventricles, then you get your QRS complex. But everything before that is all contained within your PR interval. And I think that's really cool. So here's a great representation of all of this. So color coded, we've got your SA nodes like right? I'm gonna like send out an electrical impulse. Your atria are like, yeah, let's do it, right? And then it hits your AV node, it slows down a little bit, hits your bundle of his, hits your bundle branch, hits your Purkinje system, and then your ventricles in this black. They're like, yep, okay, let's do it, right? But everything in your PR interval, that is almost all of your cardiac conduction. Then we get to your QRS complex. Super boring, but really important, right? So your PR interval like carries everything. It shows like everything. And then we get to your QRS complex. That's ventricular depolarization, and that's really important, right? So your ventricular depolarization and conduction 0.06 to 0.11 seconds. So when we get later on, anything greater than that, 0.11, so 0.12 seconds and greater, we're going to call wide. So this is ventricular depolarization. We've got the impulse to the Purkinje system, to your ventricles. Ventricles depolarize and contract. Pump blood to your body. If we were to break down the QRS complex, we can measure the intrinsicoid deflection, which is really cool and a really fun word to say anyway. So I'm going to say it again. Intrinsicoid. Intrinsicoid deflection. It's really fun. Try it. Try it out at a party. No one will like you. It's okay. Intrinsicoid deflection. So, what it is the beginning of the QRS complex to the top of the R wave, the peak of the R wave. And what that measures is the time that the electrical impulse takes to travel from the Purkinje fiber to the outer epicardium. That's pretty cool. I think that's pretty cool. This will be a little important when we get to kind of like wide complex rhythms. But the intrinsicoid deflection, again, I'm just going to keep saying it, intrinsicoid deflection, because that's fun to say. Time it takes to get from the Purkinje system, the Purkinje fiber, to the outside of your heart. Okay, intrinsicoid deflection, not that important. But what is really important is the ST segment. And we're going to talk about that a lot in a few weeks from now, especially when we talk about MIs, myocardial infarctions, ST elevation infarctions. We're going to talk about ST depression and ischemia. This is really, really, really important. So the ST segment itself is the segment between the end of the QRS and the beginning of the T wave. So that little section between the end of the QRS and the beginning of the T wave. And we're going to call the end of the QRS the J point. I don't know. I don't know why they pick that. That's just, I didn't pick that. J. Why J? I don't know. I don't know why J. Don't ask me. Please don't ask me. It's called the J point. But there it is. So, QRS comes down, comes into the ST segment. Where it comes in is called the J point. And later on, we're going to focus a lot on the J point. But right now, just know that where the QRS comes into the ST, called the J point. For whatever reason. Because it's alphabetical. And J obviously comes between R and S. Because, it's J. Moving on from the ST segment and why the J point is in between R and S is the T wave. So the T wave is ventricular repolarization. Your T wave should be asymmetrical. So here we have a T wave. It looks a little funky, right? Doesn't. Oop. That was my bad. Sorry. So this T wave isn't symmetrical. It's got this like upslope and it's like steeper downslope. So in like shallow upslope, deep downslope. So your T wave should be upright in most leads, and we'll get to that later. But your T wave should be upright in most leads, and it should be asymmetrical. Now, what do we mean by symmetrical? Well, I should be able to take my wave, take it at its peak, cut it in half. And if it's asymmetrical, that's a normal T wave, take it at its peak, cut it in half. I should have two separate halves, two different looking halves, I should say. My symmetric T wave, if I cut it at its peak vertically, I have two equally looking halves, and that's not a good thing. Those symmetric T waves are an indication of a number of problems. So, in my normal patient, I should have a normally asymmetric T wave. Don't you worry. We're going to get to those T waves later on and really kind of dig into them. But we're going to continue on. We're going to talk about this QT interval. So we're going to measure from the beginning of the QRS complex to the very end of our T wave. That's going to be our QT interval. Beginning of the QRS to the end of the T wave. This represents the beginning of ventricular depolarization to the end of ventricular repolarization. So it is the entire ventricular depolarization repolarization cycle. It's everything. The QT is everything that our ventricles do. And we're going to measure this, our QT interval, because, you know what? A short interval tells us a few things. A prolonged interval tells us a few things. And a prolonged QT interval might be life-threatening because of those R on T complexes, right? If we think back to our action potential, what does an R on T complex do? Might throw us into a ventricular rhythm. So we're going to pay attention to this QT interval. But we don't actually care about the QT interval. And I know you're sitting there, you're like, you know what? No. Nope, I do care about the QT interval. Yeah, we do. But we care about the corrected QT interval. So the QTC, the corrected QT interval. And what are we correcting for? We are correcting for the heart rate. And there are a whole bunch of formulas up here for you. There are 4 of them. A lot of algebra. But they're all correcting for heart rate. That R to R is heart rate. Because at a higher heart rate, our QT interval is naturally shortened. And a slower heart rate, our QT interval naturally lengthens. So if I have a heart rate of 40 and you have a heart rate of 120, our QT intervals are going to be different. So we have to find a way to compare the two. My heart rate of 40, your heart rate of 120. We have to find a way to compare those two. So we correct this QTC. We correct for heart rate. And there are a whole bunch of formulas. There's one in your book. It's down at the bottom. Garcia. It's an algebraic thing. There's a linear method. There's a whole bunch. What I want you to focus on is an easy one. It's QT divided by the square root of an R to R. So measure your QT. Measure an R to R, and then do the division. You might say, well, what's the difference between all of those? Well, this one, the one we have circled, is the easiest one to remember. Honestly, I mean, it's the easy one. You can do the one down below instead of a square root as a cube root. Go for it. Have fun. I don't know. You can do this linear and memorize that. Go for it. I don't know if you want to. Garcia, as well as like another linear. Go for that if you want to memorize that. But QT over the square root of R to R is so easy to remember. And then if you look at a graph, I'm gonna make you look at a graph, right? So this is the most accurate that R to R over the square root. Excuse me, I just messed that up, didn't I? QT over the square root of R to R is the most accurate QTC measurement if we're doing it by hand. So there it is, right? And you're wondering, like, why do I care? I don't care. That's what you're saying. I know what you're saying. You're saying I don't care. I'm kind of saying I don't care in my head right now, and I'm the instructor. But this is what I did day in, day out for my first medical job. I should say my second one and a half medical job, second medical job. I started out as a unit secretary, but then I cross trained as an EKG tech, and I did this every single day by hand for every one of our patients, and we had 20 beds, 20-ish, 20, 22, 20 or 22 beds in our unit, and I did this every day. QT over the square root of R to R. I did that by hand for everyone every 4 hours. Do it. That's how you find your QTC. That's what you do. Moving on. I'm sorry for that rant. Okay, moving on. So there is a U wave. There might be a U wave. I don't know. So the U wave is a really small, really flat wave after the T wave. It might be there, it might not. Usually it's not. Sometimes it might be. Um, we don't really know what it is. We think it's endocardial repolarization, but that's the leading theory. So we'll get into the U wave in a few lectures from now when we talk about potassium and its effects on the EKG. But just know that there might be a wave after the T wave and before the next P wave, and we're going to call that a U wave. As always, if you have any questions, please reach out and let me know.